A topic that really kind of piques well as those of our staff at both of our institutions. Um, and there's a lot of experience in simulation, and there's also a fair amount of efforts in interprofessional education. And we are going to be trying to combine the two. Um, However, the evidence combining the two is still not quite solidified, but we'll get to that in a few minutes. So the objectives that you can see here should be on your screen, but there's going to be three main objectives for people who want to incorporate interprofessional education into their simulation. And the main one is going to be to improve the communication and the performance, with the ultimate goal of improving their patient care outcomes as well as satisfaction. But like any undertaking, there are going to be some fairly common and unique challenges with the interprofessional education. But these challenges can be overcome to have a excellent experience for those who are caring for their patients, either in the clinical setting in a hospital or in the pre-licensure level in school. And then finally, we'll talk about developing kind of a framework for anyone who either has started interprofessional education to improve it, or for those who haven't, where to get started. Okay. For those of all of us that are in the simulation realm, we're going to start with some definitions. You will see here, the simulation, and I'm not going to read this verbatim. This is for your reference, and I want to just put this up there, but I want to focus most of our discussion today not so much on the simulation part, but some of the unique aspects of the interprofessional education, and how we can develop that for our trainees and staff. So there have been a variety of definitions that have been proposed. So IPE refers to those occasions when members or students of two or more professions learn with, from, and about one another to improve collaboration and the quality of care. A second definition proposed by Hale states education initiatives that incorporate interactive learning methods between different professionals in order to foster collaborative practice. Both of these definitions have a similar flavor, but what you will notice is missing from that is a real discussion on specific medical knowledge per se. And that's what sets IPE apart from some of the other simulations that we do, where our focus is primarily procedural skills or knowledge. IPE is really going to focus on the communication and the challenges that occur during these exercises. So what IPE is not, it's not shared listening. It is not having someone give a lecture and have different uh, professionals in the room just receiving a lecture and not interacting. And so it's not learning in parallel, which is very similar to the first one. And there's not a lot of medical content, foci or profession-specific content. This is inevitable in the training itself, but it is not the primary goal uh, of the IPE simulation. When one looks at the literature, you'll see a variety of different prefixes and suffixes used, and it can actually be quite confusing. You will hear interdisciplinary, transdisciplinary, multidisciplinary, and various combinations. Most of the literature is trending towards, or has already trended towards, a specific definition for this kind of training, And pretty much a standard is going to be interprofessional education, although you will frequently hear this as referring to multidisciplinary, was probably the second most common term that is used to discuss this process. So I'm going to talk about some key assumptions, and I put assumptions here in quotes for a couple of reasons. We all feel deep down simulation makes sense and should be effective, and there is quite a bit of literature that supports that. The outcomes and some of um, the final outcomes that some like administrators will look at still remains to be seen. IPE also makes sense and should be effective. So when you combine these two, one can intuitively think that simulation using IPE makes sense and should be effective. So is this really true? We suspect that it is. The methodology of the study needs to be refined a bit to make the study of this method of education more rich, and cause and effect has not been truly established, and the research of this is still lacking and is also in the development as um, the healthcare environment mandates improved communication among healthcare providers. So there are several goals for IPE. One is to develop the interdisciplinary knowledge, skills, attitudes, and how to work together. This can be difficult at times, and we all have experienced this when you have different disciplines involved in the management of the patient, and we all do not necessarily agree or communicate very effectively at times, and this is even enhanced in a negative aspect at times during a critical situation. Another goal is to develop students who have the knowledge, skills, and attitudes to become collaborative practitioners who work together in an effective collaborative fashion. So similar to the first one, but this one is more aimed at your pre-licensure professionals. So those that are still in school, so they actually will have the experience of how to work with others from other professions. Finally, learning role demarcation versus role blurring, group skills, communication skills, conflict resolution, and leadership skills. For me, this is perhaps the most important part of interprofessional education. It, as we all go through our training in school, we learn the knowledge and the clinical aspect, but when it comes to real life and how to best take care of patients, communication skills and particularly conflict resolution become vital characteristics and qualities that should be discussed and practiced. So why implement IPE? So the Institute of Medicine, as we all know, um, 2003, health professionals should be educated to deliver patient-centered care as members of an interdisciplinary team, emphasizing evidence-based practice, quality improvement approaches, patient safety, and informatics. And so part of this is driven at the, not at so much the institution or regional level, but whatever country or country you're in, but those at a higher level. But aside from what has been outlined by the Institute of Medicine, it seems intuitive. Uh, we should strive to improve communication, our coordination of care, and our optimization of roles. As medicine becomes more complex, there is a further demand for those people that are taking care of patients, particularly since we are getting very sub-specialized in certain areas to improve the communication. And again, this is all to take care of the patient, improve their patient care and their safety, as outlined in the last bullet. IPE also addresses teamwork, communication, and conflict issues with the goal of moving towards a resolution. Um, it is unfortunate at times that these issues come up after or during an actual patient care case, and if we have the necessary tools and are taught how to do this, that it can improve when the actual clinical situation arises. Another subcomponent of why implementation of IPE is important is to eliminate, ideally, but perhaps to minimize the professional stereotypes. Okay, these are ubiquitous, whether many of us would like to admit this or not, but nurses have stereotypes of physicians, physicians have stereotypes of nurses. Some people may have stereotypes of other allied health professionals, whether they be physical therapists, occupational therapists, pharmacists, and so on and so forth. And it also helps to develop an appreciation and insight into others' contributions to patient care. We all think that our role is very important with regard to any specific patient. But we're also not the only ones, or rarely ever the only ones, taking care of someone, a pediatric patient. And so this really allows the group to come together so you understand your roles a little bit better and also have some insight and what others have to offer that patient and how that fits into the overall strategic management in their care. And as I alluded to, the ultimate goal is to improve the patient care and the safety. So there, despite my slide few slides ago where we're not sure about the outcomes, there are some evidence of outcomes in certain fields that have been reported. Some of this has been in adult substance abuse and some family care, and also with I believe palliative care, if I remember correctly. Perceived benefits to patients and outcomes seem intuitive. And we've already kind of addressed the increasing complex medical care demands improved collaborative relationships. And using the simulation, most of the participants that have used IPE have demonstrated a favorable attitude towards it after its implementation. So there are many challenges. So we've kind of gone through why you should consider IPE, or at least have it as an option for something to offer your facility or your department. However, there are still quite a few challenges. One of the most important ones is, when should interprofessional education be introduced? There is still a considerable amount of debate. You basically have two camps. You have a pre-licensure camp versus a post-licensure camp. Um, those advocating the pre-licensure introduction, so those that are still in nursing school or medical school, they should be introduced during that time. That way they become acquainted at a early time in their training, and this not only helps you appreciate other schools, but it also helps to minimize the stereotypes that sometimes develop as we all go through our education. However, the post-licensure school has a good argument in the sense that we perhaps should not be introducing those still in their formal training too early and become involved, because they are still trying to develop their identity and their confidence in their specific field. And so some people would argue that introducing them too early can actually be more problematic, in the sense they don't have really a lot to add from their specific profession. So this is one of the most debatable topics that comes up with the IPE. The next bullet current culture of school and profession socialization, I've already kind of alluded to, but most of us during our training are trained in silos. Again, whether this is allied health, PT, OT, we kind of we're in the classes with most of our colleagues pretty much for those few years, and there's not a lot of mixing up between the different schools. Finally, sorry, not finally, one of the time, as we all know, is utmost important. It's also doesn't come very easily. And for those that are in training, there's usually a dedicated time for the IPE. However, when you are out of nursing school or you're a resident or even staff, the time that is available is very rare. And so allowing or encouraging interprofessional education becomes a bit more difficult in the postgraduate environment. And that kind of alludes to the few, the proud. Many people who are involved in the interprofessional education are advocates for it. And so the people that you do have that are interested about it and supportive of it are obviously the ones that are going to be participating. Unfortunately, what happens is if some of those people who are your best advocates, if they leave, then that really affects the overall purpose of the IPE program as well. Administrative buy-in, as we all know, when we're trying to incorporate a new program or change our curricula, time becomes very difficult. We all and I speak from in the post-education, postgraduate environment, and in the clinical realm, we have become so efficient what we do, and there always seems to be other priorities for time. And so, like anything else that we do, time is very difficult to obtain. And finally, are the financials. How are you going to, you or administration or the institution you're in, be able to justify the time to support this when the faculty or staff could be doing clinical care? And so, a quote by Gordon, the ability to practice without risk must be weighed against the cost of this new technology. And so, this becomes a more active discussion at the administrative level. So here we have some more challenges. Okay, there's really minimal real life exposure at times, and for a person who really is an advocate of the education for our residents and fellows, with the limitations on the duty hours that have happened over the past 10 plus years, there has been a fairly significant decrease in the amount of time that residents and fellows are able to have these encounters. Furthermore, educational institutions and hospitals, they have been significantly, there's cutbacks, particularly in the past 6 years with the economy. And as most of us know, that education is unfortunately one of the first things to get cut back, whether it be at a national, regional, institutional level. And so it becomes very difficult to support this at times when the financial situation is not particularly clear. So IPE, it's a significant cultural shift. And this again goes back to how most of us have been trained. We've been trained in traditional silos in our area of expertise. And this is a very difficult, I think, an underestimated um, obstacle to many people. We assume that people in the medical profession know how to work with each other, but that's not always the case. Um, The next bullet refers to we have ever increasing clinical and teaching loads, and again, this becomes a time issue. And then finally is how do we adapt this type of education into current or even new curricula? Okay. All right. So one piece of advice that I would have, and that is resonated throughout the journal articles I looked at, is that you really need to look and think ahead before you start incorporating or attempting to incorporate IPE into your curricula. You really need to outline your reasons and your goals for implementation. And this will help you as you pursue this, collect your thoughts, but perhaps even more importantly is that it will be obvious to others that you've thought this through. And so when you go to either the department managers or administration to help with instituting this, you may have a better chance at success. So I think of this almost as like a business plan. So you need to really identify and include your key stakeholders from the very beginning. And I probably cannot overemphasize that enough. Um, you need to anticipate resistance and challenges to interprofessional education from some, not everyone. You will have probably many supporters, but you may also have some people who are questioning why the introduction. So, for example, if you are proposing that your department start incorporating simulation-based interprofessional education, there may be a lot of questions. Well, why are we, what is the need for us to do that? And people are going to assume, based on the introduction of this program, that there's something wrong with the current system, which may or may not be the case. And so it may need to be pitched in a different perspective, in that you are trying to improve the overall quality, not necessarily make a huge change. And then you need to develop a systematic approach to the development of your curricula. This is a slide taken out of Naismith in 2003. And this kind of serves as a overall really good outline of as you think about developing IPE for your program or institution. This kind of gives you a format for you to run down so you don't miss anything. And so I'm not going to go over this every line in detail, but you will see that you are, identifying, what is driving this change, who are, partners of it, and so stakeholders. What are the opportunities? So, are the opportunities for the patients? Are the opportunities for the learners? You need to identify the barriers and difficulties. And like all curricula, you need to develop specific objectives for it. And again, this becomes important for you as the educator, as well as for those who you are pitching this to. And then the final two, evaluation. You need to see how this is performing, okay? And you may or may not have outcomes. You may or not have a specific impact that you can measure, but you may be able to improve the satisfaction either of your patients or their parents, or say your nursing staff, which if you improve those latter three, that may be sufficient to justify the continuation of your program. And then finally, all of our favorite one is going to be funding. And so you need to identify a way for this type of program to be sustainable. There are quite a few different educational theories, but perhaps the most important educational theory as it relates to both uh, simulation as well as IP is going to be experiential learning, and as described by Kolb. And so this is going to be a circular type of learning process where you take an abstract conceptualization, okay? So say IPE, you do some active experimentation. So you get people together, present them with a clinical problem, and then you see how they approach that problem through collaboration in a concrete experience such as simulation. And then there needs to be some reflective observation. There needs to be some review on the part of um the trainees or the learners to actually step back from that simulated experience to see how things went. Um, and this is something that all of us know from participating in simulation. So how does one develop a specific curricula for IPE? As we all know, you need to have relevant curricula, and this will result in an improved experience, okay? Adult learners, again, using simulation, you have to make the educational experience relevant to their job performance, and without this, there's not going to be a lot of buy-in. You also need an explicit orientation for your group members. So you need to explain why IPE is potentially beneficial, what the overall expectations as well as anticipated outcomes are going to be. You also need to really consider whether this is going to be optional or required. Okay, so if this is an optional exercise, you're probably going to get many of the people who are the go-getters and might actually already be ones who are uh, doing that have good interprofessional skills. And the ones that you're going to be missing by having as an optional experience are going to be the ones that probably need the most experience. However, if you make this required, then that opens up another can of worms, and you may have some resistance of yet another educational thing being imposed on you. So you have to consider the optional versus required part of this activity for your wherever you work. I'm not going to discuss the pre-licensure or post-licensure. I think we discussed that in a fair amount of detail before, but there is a pretty significant there are reasons for introducing the pre-licensure as well as not to. And then you need to incorporate active learning strategies, okay? And these include involving the learners, making them participate, and also reflection is a key component. This is not a passive learning environment. Some further thoughts on the curricula. I mentioned earlier that it's not so much a medical knowledge that will invariably come up as you do a simulation-based exercise with a variety of professions. And so an example might be, and I'll use my arena in the PEDS ICU, is if we have a heart patient who had recently had congenital heart surgery who is decompensating. And so when that happens, typically we will have a cardiothoracic surgeon, a pediatric cardiologist, an intensivist, pharmacist, nurses, and kind of a smattering of a few residents and medical students. And so as you can imagine, the things at times can be a little tense as that resuscitation process uh, is performed. Okay, so now if you take a simulation exercise with this kind of background in mind, the overall goals are going to be not so much discuss the medical decision making, but it's going to look at some more gray areas such as hierarchy, whether implicit or explicit, role blurring, okay? And for example, you may see some of this between the intensivist cardiologist and the cardiothoracic surgeon, leadership, decision making, who ultimately gets the final decision, communication, and then also respect. And the respect issue is a very important one, and that goes from the surgeon respecting the nurse and nurse respecting the surgeon, and realizing that we're all trying to do the best thing for this child who is deteriorating, but we need to be able to do that in a professional and a courteous manner. The next point is kind of a reiteration of previous discussion. We need to allow time for the review and reflection. So after you perform a simulation where you have multiple professions involved, you need to take time to brief, have them review, and they need to reflect on the experience. And this is where the deep learning is actually going to take place. We've discussed whether this will be elective or required. And you also need to tailor the curricula to make the education, the IPE, pertinent, applicable, and worth their efforts. Okay. Couple more slides. All right. The environment needs to be non-threatening, safe, and collaborative. Kind of a no-brainer, but you need to focus on that as well as ensure those that are participating that it is a safe environment to work with. Group balance is very important. Okay, it is helpful if you do not skew it towards a particular uh, profession, and the balance can affect the overall experience for all the members. For the size, 5 to 10 members is frequently quoted in the literature, and this is reasonable. If you get over 10, it becomes self-defeating, and you get a bit of a bystander effect. And perhaps 5 to 8 is probably the most ideal. And I've already talked about stability and how if you have any members who are involved in this, turnover can be problematic and detrimental to your overall program. Okay. For faculty development, this is this is more aimed at faculty um, who may be more set in their ways, but it is very important as you introduce IPE for the faculty to know that they need to walk the talk. And so they need to practice what they preach. And if they're involved in this at the training, then they really need to be cognizant of how they are performing in the actual clinical environment. If you have a facilitator who teaches IPE, but yet in the clinical environment is not very approachable and violates some of the core tenets of interprofessional education, that program is not going to go very far at all. In these simulation-based scenarios, the person who is instructing should be considered more of a facilitator versus a teacher. And that person really needs to anticipate interprofessional friction. And so he or she really needs to expect that that could be a problem and then know how to address that. And they should also have an intimate understanding of the power and the hierarchy in that local institution. And again, this is either implicit or explicit. And we all carry our own biases, attitudes, and stereotypes, and it's important for any one of us who are leading these sessions to really dig deep and to recognize that despite our best intentions, do carry our own biases and stereotypes, both to the educational sessions, but as well as into the clinical realm. All right, so evaluation and outcomes. I don't want to make this shouldn't be more labor intensive than it's supposed to be. You need to just evaluate your program and assess your learners. You need to identify what you feel is important for your, again, either unit or program or department, and decide what works best for you as well as what you're trying to assess. Unfortunately, there's been a lack of evidence supporting some improved outcomes, and again, this is not I guess, really unexpected. I think this was out of a Cochrane review. Um, and so this kind of reverberates a little bit with how simulation has been viewed at times. But I think my favorite quote is from Zorenstein, who states, "No evidence of effectiveness is not evidence of ineffectiveness," which I really think we need to um, take to heart as we develop these types of programs. As you're evaluating your program, you need to look at a few things. And so this kind of gives you a template. This is from Freeth in 2002. You need to look at the reaction from the learners and see what their impression is and what their experience is. Okay, if you have nurses who find this type of experience exceptional, that goes a long way for satisfaction in their at their job. Okay. You can have modifications of attitudes. All right, is this something that you see after doing these exercises? Acquisition of knowledge and skills. I have not focused on that too much with regards to IPE. However, this could be a component that you may look at. The next one is behavioral change. And is there a demonstration, and not just someone's attitude and what they, say in a Survey Monkey, but is there a demonstrable change in their behavior as a result of these exercises? And then this can go down up the food chain, and you talk about organizational practice. And again, the ultimate goal, again, whether we can prove it or not prove it at this point, is improvements in the health and well-being of our patients and clients that we take care of. All right. So finally, summary, keys for success, cooperation, assertiveness, responsibility, autonomy, communication, mutual trust, and respect. So these are all ways that one's IPE program will be successful. And I know the assertiveness and cooperation can kind of seem contradictory. However, if you have a environment where people respect each other, is certainly possible and appropriate for people to be assertive, but in a respectful and cooperative way. Another excellent reason for IPE is you know each other's roles. You have good communication skills, and I reflect back to my fellowship with regarding know each other's roles, and we did a month of as an elective. And what it was is spending a week or two as an RT, and then a week or two as a nurse. And I made the tremendous mistake of thinking it was going to be an easy rotation. And well, I tell you, after one or 2 weeks of doing the responsibilities of our nurses in the ICU, you truly have a more of an appreciation of the work that they do. Um, Going back to the bullet, so willingness to work together, you get self-confidence, not only in yourself, but also in others, mutual respect, and again, you appreciate others' contributions. And finally, I can't overemphasize the importance of early planning and identifying your stakeholders, and try to minimize your professional specific topics. That way you don't alienate any specific group. And I think that is the end. The references I've included, there's probably about 15 or 20 of them. The ones that are in bold are going to be the ones that I relied most heavily on for this